And welcome back to the morning show. I am Marshall Shore.
And I'm Melissa Farley. We're here
At
at the fabulous Arizona
Center with that amazing view. Oh
Yep.
my gosh. I mean, this is our second week in the studio.
I know.
Yeah, very exciting.
We're still not over it. We still get awestruck by this view. It's pretty incredible. Actually, one of our guests just recommended that we put a mirror up on this wall
so we could
see it.
Oh.
Yeah, because it's behind us.
Oh yeah, we could get some of those 60s with the gold veins in them and everything.
Okay.
Yeah.
Sold.
All right.
Well, we have a wonderful guest here for you. We've got Tammy. Hi, Tammy.
Hi there.
So nice to have you on. You are with Precision Regenerative Medicine.
Yes.
And so many questions. Oh my gosh.
Marshall's like, I can't even wait.
What
is it?
What is it?
Yeah.
Exactly.
What is regenerative medicine?
Yes.
I'm going to focus mostly on musculoskeletal. There is a whole huge, I guess, world of what is regenerative. When we're talking aesthetics, we're talking about maybe biohacking, we're talking longevity or health span, lifespan. But what I do is specifics to the musculoskeletal system. So think any of your joints, your spine, and I do still use biohacking to make the body ready for using its own cells. So that's where we talk about the regenerative.
Okay.
Originally you'd think, ooh, does that mean we're going to regrow a knee and I don't have to have a knee replacement? We're not there yet. Not quite ready for prime time, but we can optimize you and then harness your own cells to help decrease inflammation, decrease pain, and maybe keep you out of the operating room for as long as you need to be.
Okay, that's interesting. So you say use your own cells.
Yes.
Yes. Okay. So I know you're around this all the time. You work in this. So somebody that's totally new to this whole concept of regenerative medicine, what does that mean exactly, to use my own cells? Like, is it done in a blood pool and then it gets put back? Like, how does this all work?
Perfect.
Yeah.
Can I start with what is traditional and then we can compare to what is regenerative?
Please
Absolutely.
do. Yeah.
So traditionally, say you were an athlete, you are an active mom, you are a granddad who wants to play on the floor with your kids and your grandkids and you can't because your knee hurts. And you would go to maybe your sports med doc, maybe your family doc, and they say, it's probably just some wear and tear arthritis. Let's try a steroid injection into the joint. And they may just kind of feel around and say, okay, that's a spot, go. And put some steroid in there to reduce some inflammation. And maybe you step it up, and the next step is the gel shots, where you get a little hyaluronic acid, which is part of our normal fluids and cushioning device. So let's try to maybe add some fluid to that as we get to bone on bone in the knee.
Okay.
Regenerative medicine goes above and beyond that. Because now we know that steroids, even one dose, can accelerate cartilage loss, can accelerate osteoarthritis.
Well, that's great.
I know. Thank you for that.
Wow.
Okay.
I had no idea.
I know, and a lot of people say, well, I get 3 shots a year.
Yeah.
Or 4 shots a year, however much their doctor doles out. And these
Right.
are massive doses. To be clear, we make our own steroids. We have these teeny weeny little glands on the top of our kidneys called the adrenals, and they make steroid, but in these micro doses. So when you get injections anywhere, be that your knee or your tennis elbow or your epidural steroid injection in your neck, that is a massive dose, thousands and thousands of what you need, and it overdoes what it's supposed to do. So we don't want the tendon to rupture because it weakens tendons. We don't want to accelerate the arthritis. So we said, the body has its own way of healing itself. I'm an osteopathic physician. I'm a DO. DOs and MDs get almost the same training. It was actually an MD who was not pleased with, I've either got a pill or I've got surgery. There's got to be a better way. So he brought in osteopathic manipulation. He brought in, we've got to take care of the being, reduce the stress, improve the sleep, improve the eating, and the body can get over things.
Yeah.
So that's the osteopathic principle. So that fits perfectly with me quitting traditional pain medicine, never burning nerves again, never injecting corticosteroids, and saying, what if we can't use your own cells? Meaning the baseline for regenerative medicine would be blood, platelet-rich plasma.
Okay.
Typically, you draw blood from this area of the arm, you spin it in a centrifuge. There are high quality tubes to put the blood in and low quality tubes, high quality centrifuges and low quality centrifuges. So we can talk about that in more detail. But you spin it, then you separate out the red cells, which aren't part of regeneration. But in this tiny little layer at the bottom are platelets and growth factors and anti-inflammatory cytokines. So think of steroids on steroids.
Okay.
But it's not a steroid, and it's your own cells. So when that's then precisely placed into the area of injury, like a meniscus tear or like inside the joint where there's getting to be bone on bone or some wearing and tearing of the cartilage, then that tells the body, come here. This is the time to work. We are calling all available people here, and let's start working on this. So over a course of several months, this is not fast like a steroid injection. It starts reducing inflammation and healing. We hope that it will create a situation where you've got more function, you've got more capabilities, and you're staying out of the operating room. It is now known to be a disease-modifying substance, meaning like you would take an anti-rheumatoid arthritis drug and it halts the progression. We're finding your own platelet-rich plasma, when it's high quality, is also a disease-modifying drug. But it's yours, so it's really not a drug.
That's fascinating. Okay, so maybe an obvious / dumb question, but why isn't everybody doing this then? Is this fairly new? Is there just not a lot of education or awareness around it? Like what's the situation there?
I think there are a couple things. A, it's not a dumb question. B, it's been around for decades, was originally kind of brought to the light by our dental colleagues because they would put a platelet-rich plasma kind of clot, fibrin clot in the area around an implant to make it more likely that the implant would succeed.
Interesting.
And then our veterinary colleagues said, ooh, this could keep the racehorse on the track. This could keep the show dog who's doing all those little slalom courses on the field. And they actually have a lot of data that we can transfer over into humans. I'd say the biggest boom for human studies, probably 20 years, but it's becoming more and more. I think in 2025 alone, there have been something like 160 randomized controlled trials on platelet-rich plasma. So if people say, oh, this is experimental, this is not ready for prime time, it truly is ready for prime time. And I can list, just today, a long list of probably 24 just on the spine with platelet-rich plasma, or just as many on bone marrow, which would be another use of your cells, or adipose, fat. People say, oh, I've got plenty of fat, let's use that, right? So these are your own cells, but it is ready for prime time. Another barrier is that insurance is still calling it experimental. It's
that's kind of what I thought. I was like, it comes down to.
It kind of does, because Marshall, can you put a patent on blood? Can you put a patent on your own bone marrow?
Yeah.
No. So where's the money?
Yeah.
The money is in drugs. The money is in hardware.
Yeah.
The money is in industry. And so there's a lot of things that will come out that say, oh, PRP doesn't work at all, or it versus a steroid and they're equal. What did you actually draw? Did you use a simple little test tube and it was this much, like 7 cc's of blood, which is literally a tablespoon? Or did you use 60 cc's? Let's just say 6 and 60.
Yeah.
Well, that's 10 times. And if you spin this down and you concentrate it, are you maybe not going to get 10 times the platelets? So now we know that there's a dose response curve. So if you put in plasma, you're not going to respond. If you put in platelet-rich plasma, whether that be a magic dose, which we think is closer to 10 billion from a 60 cc draw.
Okay.
That would depend on your health. That would depend on your baseline platelets. Do you have a clotting problem where if you cut yourself shaving, you don't stop bleeding? But if you've got a normal platelet, drawing about 60 cc's of blood will yield 10 billion platelets, and that appears to be the magic number for at least the knee. I extrapolate that to the other joints, like the shoulder, like the hip. And in the spine, I'll draw 120 cc's because I've got so many more targets in the spine. So you have to know that a lot of this out there is maybe manipulated for the use of the insurance industry or industry in general to say that the deck is stacked against, why do you want to do something experimental? Why do you want to do something that insurance won't pay for? Why?
Yeah.
So, is it something, I mean, so do those platelets, someone who's 20 versus someone who's 60, same number? I mean, I'm just wondering, it's like,
do you decrease value with
yes,
age?
exactly. That's what I'm wondering. It's like, I mean.
Yeah.
That is a great question, and originally everybody thought for sure, and I can definitely say with bone marrow, they say because bone marrow has everything platelet-rich plasma has, plus it's got your own stem cells. So your own mesenchymal stem cells, meaning that they're the kind that differentiate into things like bones and cartilage and ligaments and tendons, think musculoskeletal, and we've debunked that.
Yeah.
We've said that's a myth. Let's bust this myth, because if you've got excellent technique in getting the cells, the way you prep the patient, the way you harvest the cells, I know that sounds like a weird word, but literally you're taking the cells, but you want, like when you harvest a crop, you want to make sure that it's been well watered, you want to make sure that it maybe has some organic fertilizer, those things, then you can get just as good a response in an older population than in a younger population. So I love that question because I love to bust the myth.
Yeah. So selfishly, I'm curious, and if this isn't your area, that's fine, but I'm just curious, like, so I have a very weird type of migraine that affects my nervous system and my muscular system. And there was an instance a couple of years ago where they gave me like a shot in my spine. It ended up triggering thyroiditis, and I just had a really bad response to it. But I'm thinking about, right, like how many meds I take to treat my migraines, and I'm curious, like, is it at all possible that something like this could be applicable to a kind of migraine situation?
Potential when we talk about what kind of migraines, and if there is, for example, anything involved with the occipital nerve.
Yes.
So occipital neuralgia, or it's a little nerve that sits at the base of your skull, and it kind of creates this
That's
type
where
of
mine start.
Yes.
Yep.
This pattern. Yep. That nerve can become entrapped, and the muscles around it can just almost choke it. Well, imagine if you're choking, you can't breathe, you can't get oxygen to the area.
Yep.
So with platelet-rich plasma, or even something as simple as dextrose prolotherapy, that's sugar water, sterile sugar water, placed under ultrasound around that nerve. It's almost like taking, I liken it to a cotton ball where you've got all these fibrous things, and you've tried to get this little stick or this nerve up through that cotton ball, and instead it kind of goes puff, puff, puff. And now there is flow, now there is oxygen, now there is life back to that nerve. Yeah. So it may take a couple of different times, but targeting the nerve, targeting the muscles that are also now fibrosed, and the fascia, which is kind of like little saran wrap around each muscle, loosening those up and freeing them can often provide amazing relief, particularly with cervicogenic headaches and migraines.
Interesting.
So yes.
I'm fascinated by that. Okay. Yeah, no, because I mean, it's just that, mine start literally here, go up and over one whole side of my face and head, but then it goes into one whole side of my body. And so it's been a struggle. And so now I have an injection that I take, but that's something that I've just always wondered why there's not been more kind of just research or information that I have available to me about like options and why this is happening.
Well, it sounds like at the end of her segment, she's going to give a little how to get more information. You might want to reach out to her.
No, I know. So is there anything, what else should we know? I mean, this is clearly new to both Marshall and I. It's probably new to a lot of our viewers. Is there anything else that you'd like to share that we should know about the kind of medicine that you provide?
I would say that the most important questions to ask when you're looking for somebody are not so much what's the cost of your PRP? How much is PRP? How much is PRP? Because not all PRP is created equal.
Okay.
You want to know how much blood they're drawing, dose response curve, a little test tube versus 60 cc's.
Okay.
You want to know that they want to know your labs before.
Yeah.
That it's not going to be that I meet you on the same day as I inject you. Because I don't know you yet. I
Yeah.
don't know that maybe you've not stopped medications that would have poisoned your platelets, like ibuprofen, naproxen, Aleve, meloxicam, any of those NSAIDs, any of those things to destroy the platelets. Well, within the platelets are the growth factors, so you're just wasting your money. That would be a big waste of it. So you want to have met the person, know who they are, what their training is, that they didn't maybe take a cadaver course over the weekend and decide that, hey, I can inject the spine versus a spine fellowship trained
Yeah.
residency fellowship, and I know what to do with complications, and I have neurosurgeons or orthopedic spine surgeons. Should there be a very rare complication, I have admitting privileges and can do that.
Yeah.
And not every practitioner can.
Okay.
So unfortunately, it's kind of a wild, wild west.
Yeah.
We live in Arizona, but it's a wild west everywhere with regard to this kind of therapy. So not what is the price of your PRP, how much blood are you going to draw, what is your training,
Yeah.
are you going to use image guidance,
Okay.
an ultrasound and or a C-shaped x-ray if we're talking about the spine to deliver those cells exactly. Because even if you're an amazing orthopedic surgeon who's injected 5,000 knees, the studies have shown that palpation guided injections of that knee versus an ultrasound guidance, you cannot compare the accuracy. And when we're talking about injecting, we want to treat the whole. This is an organ. This has cartilage, this has synovial fluid, this has bone. All these can be targets. Then we've got the meniscus, inside and outside. We've got the ligaments on the inside, outside. We've got the crossing ligaments.
I was
This
going
is
to say, you have a model.
This is a whole organ. So you don't just want somebody to put it in the joint.
Yeah.
That'd be like going to the grocery store and saying, I'm hungry, let me just go to the store and things are going to hop into my cart.
Yeah.
No, you got to go to the right aisle. You've got to put things in the right spot so that you can prepare that gourmet meal of all these 3 ingredients or 15 ingredients. So you need image guidance. So do you use image guidance?
Okay.
And how long have you been doing this? So a lot more than just that. And basically, what else are you going to do for me? Is it just that you're going to meet me and inject me and say, see ya, good luck with all that? There's a lot of expectation management. This is not like a steroid where maybe 48 hours after the injection, hallelujah, the anti-inflammatory has started and I'm starting to feel better for the next 1 or 2 months, and then I need another one. This is that maybe your pain started here, and here's the first 3 months. We've got a pretty steep curve where you're starting. Okay. Then it flattens out a little bit, but is still improving, and then maybe even up to a year. It can take that long to really see the effects.
Wow.
Okay. So this is a patience thing for patients.
Right.
And we want to then say, how can I optimize this? How can I make myself, the best candidate for this?
Yeah.
And that is eating anti-inflammatory. That is having enough building blocks through proteins and amino acids to actually round up all these little healing cells for your tendons and your cartilage and your ligaments. And
now I assume if somebody say, hey, I'm going to come, we're going to talk, you give them a list of like, okay, here, eat up on these things.
yeah.
Also,
So-
how long does it take to be off of like an ibuprofen before your platelets get restored?
Most people are in the 7 to 10 day camp.
Okay.
I'm closer to 10 days because I know how long a platelet lives. Others will say that if it's a stronger anticoagulant, say you've had a heart attack and some stents and you're on a medication called clopidogrel or Plavix, even though it affects the platelets, what's more important? You keeping that stent open and not having another heart attack or another stroke, or here, so I'd more likely draw more blood.
Okay.
So that I can then concentrate in those cases. But would I prefer you be off anything that poisons platelets? For sure.
Yeah,
And it
okay.
depends on that drug and its half-life.
Okay.
But typically 7 to 10 days before, 7 to 10 days after. And the longer you can stay off after, because these cells are still working, then the better you're going to do. The more likely your cells are going to be able to take.
Okay.
Great questions.
Yeah, well, again, just selfishly, I'm thinking about, because I also have a kidney disease, and so when I take ibuprofen, I can see a big difference in my levels, like on my labs, than when I don't take it. And no one had ever talked to me about platelets or how it affects other parts. I was just always thought about it in the frame of my kidneys, and so it's just interesting to hear that that's a factor here as well.
It is. They can mask some things. We actually, I know it's a little bit of a different topic, but when you sprain your ankle acutely and it swells up and you think, ooh, ibuprofen now, right? Maybe we are delaying the healing process. Our body has its own innate ability to heal, and there's an anti-inflammatory cascade that is triggered by that. So maybe it's good to lay off it, right? That whole rest, ice, compression, and elevation.
Yeah.
So putting it in an ice bucket, fine, but not too much. We want the blood flow to get there so that it can deliver all your anti-inflammatory mediators from its own cells. We might want to wrap it so it doesn't get too huge, but you don't want to just pound the ibuprofen for the next 2 weeks, because it can delay the healing and prolong the robustness of the response.
That's also fascinating. I feel like we could talk to you for
I
like
know,
a billion hours.
I'm kind of,
yeah.
it's like, wow, wow.
I know.
I mean, it's like, and if you watch commercials, they're like, oh yeah, just take a blue pill, a white pill, a red and yellow,
Yeah.
and just until you feel better.
Right. And that's
Very-
not regenerative
very-
medicine.
Right, no,
Right.
very like Stepford wife. It's like, here, just keep popping these pills till you feel better.
Yeah.
Well, thank you for sharing all of this information with us and enlightening us on,
Yeah.
I think, different options, different ways to think about things in our bodies. That is so important. Why don't you share where people can learn more about you, or if they want to work with you? That would be really great.
Thank you so much. You can find me on https precisionmedprp.com. I also have a pretty robust YouTube channel at Dr. Tammy Penhollow, and this is very patient facing. It's about free education. So if you want to learn about your knees or your shoulder or your spine, I'm publishing and releasing videos a couple times a week. If not right now, I'm in a daily challenge, so there'll be quite a few of those.
That's wonderful. We love free education around
Yeah.
here. That's great. Yeah. Well, again, thank you. Super fascinating. I feel like there's, again, so much more that we could just continue
I mean,
this
just the other door I
conversation
didn't even
on.
know was there is now open.
Yeah. So, all right. We hope your minds are as blown as ours right now, and that you take advantage of learning from Dr. Tammy on her YouTube, and also
Yeah.
reaching out to her through the website. Keep it right here, though. We've got even more awesome stuff coming your way.